Well, welcome everybody. It's 7 p.m. on February the 23rd. Thank you for joining us for our Cardiac College online series. You'll see that we have a continual set of offerings for you, and this week is devoted to diabetes. Tonight's session is being presented by me. So to those of you whom I have not seen before, my name is Paul O. I'm the medical director in the Cardiovascular Disease Prevention and Rehabilitation Program at Toronto Rehab and the Peter Munk Center. And it's always my pleasure to join you for these educational events. And these sessions really are focused on education. If you've got some very specific questions, like on which medications you might be taking, or a problematic issue with symptoms, then we'd ask you to connect in with your healthcare provider for very specific advice about your situation. We do, however, encourage you to ask questions, and I'll do my best to provide some direction and guidance or information as the situation dictates. Today's session is devoted to diabetes, medications, and the heart. We think that this is a very relevant topic because those of us who are living with heart disease or diabetes, or both together, are often asked to take various kinds of medications to help with our situations. And this slide from the Diabetes Canada Clinical Practice Guideline provides an overview of the various kinds of approaches to keeping our cells healthy from a diabetes perspective, as well as from a blood vessel and heart perspective. And the guidelines authors offer up this kind of memory aid to think about the various categories that we should be thinking about as persons living with the condition or as healthcare practitioners. So they suggest that we go through this listing of A, B, C, D, E, and S. And so the ABCs, a little bit beyond that. A is where we're going to be focusing today on ways to improve our control of glucose, or optimal glycemic control, but not to forget some of the other things that we've learned about medication therapies and other interventions to ensure that our blood pressure is at optimal levels, cholesterol is well controlled, taking medications from other categories to protect the heart, such as ACE inhibitors or angiotensin receptor blockers that we've talked about for blood pressure therapy or ways to relax blood vessels. S standing for statins and A for ASA. Many of us are taking these kinds of medicines. Don't forget the exercise and the healthy eating. And the S is thrown in to remind us to stop smoking. That's good for your heart. That's good if you're living with diabetes. But we're going to focus up here on improving blood sugar control, because we know that there is a really striking relationship between sugar control and cardiovascular risk. So this slide that looks at the experiences of about 10,000 adults who are living with type 2 diabetes, and looking at the relationship between sugar control, that's expressed along the bottom here, according to the index that you're all familiar with, called hemoglobin A1C. And then on the vertical axis is the risk of one having coronary artery disease. If we start way over here on the left-hand side, for persons with very well-controlled, perfectly normal sugar at all times, we might expect a hemoglobin A1C in the territory of 5% or less. This is kind of like the 3-month average sugar. And these individuals are expressed on this graph as having the lowest risk of coronary artery disease. At the far right is an overall average for people who are living with known diabetes. And you can see that the risk of having heart disease for all persons living with diabetes is about 5-fold higher compared to the category of individuals with absolutely normal blood sugar. And women have a slightly higher risk than men in this regards of having higher risk of heart disease. In between are the expressions of varying sugar levels according to that A1C index. And as we go from the 5% out to 6%, that starts to define us as having slight elevations in sugar, either first thing in the morning or after meals, and then getting out into territories of greater than 7%, which is characteristic of many people living with diabetes. You can see the risks go up markedly as the sugar level goes up. So the risk of cardiovascular disease rises with poor sugar control. The converse of this is ways that we can control sugar through healthy eating, exercise, and taking the right kinds of medication can really help mitigate our risk of heart disease. And so we'll talk about different approaches to getting sugar down with medicines, as well as at the tail end of this, the relative extra benefits of certain categories of diabetes medication vis-a-vis heart health. So you will find a lot of this information within the guides that are available to you on the Healthy University Cardiac College websites, as well as the Diabetes College website. And this is the picture of the manual that is available to everybody joining us today. It is our program's guide to help you live and thrive with diabetes. And what I've highlighted here is that the 7th chapter in this guidebook is devoted to diabetes medicines. And it'll take you through what your diabetes medicines do, what they are, how they can, and who can help with your diabetes medicines if needed, both effects and side effects of all of those things. So that's a resource that's available to you, and perhaps you've already looked through that. For that reason, I thought I would bring some complementary material to today's presentation. And I'm going to draw from the clinical practice guidelines from Diabetes Canada. Diabetes Canada, of course, is the volunteer organization of persons with lived experience and volunteers and professionals who routinely come together to highlight information that's very relevant to diabetes care. There's a specific attention, of course, to the different therapies that are available. I've just pulled out this particular graphic table from the guidelines. Not that I want you to look at all of the detail here, but what it does highlight for us that will inform the next several minutes of our conversation is that there are many options for management of diabetes from the perspective of using medications. These medications differ in terms of their class, the kinds of molecular structure that they might have, or that the sites where these products will work, and that they have different kinds of effects on sugar, different kinds of effects on other parts of our body, and different kinds of side effects that we should consider in choosing one therapy over the other. So we're going to go through this, the different categories here in some detail so that we can expand our understanding, knowledge about these different kinds of medicines. Once again, we'd invite you to enter in your questions as we move along. Go to that Q&A function within the Zoom platform if something pops up along the way that you'd like to ask about. Okay, so distilling from that very kind of complex table, this is the highlights of things that we should consider when choosing a medication, and there may be aspects for you as a person with a lived experience, a family member, or for us that might be on the healthcare practitioner side. So we'll think about why medication A or B. Well, let's think about the effect that that medicine might have on blood sugar. We'll think about the added benefits beyond blood sugar in terms of offering protection of the heart or protection of the kidneys, that some medicines have unique characteristics in this way. Let's think about the side effects as well. And some medicines may be prone to making sugar go down, but also maybe going down too much. Some of the medicines will make sugar go down, but also wait to go up. So then we're in this perhaps an unhappy cycle where there's good things and bad things that may happen. Medicines might be available as pills, while other medicines might be available as injections. And finding the right balance of all of these things in your unique situation is really important. And that's why there is a science to this, but there is also some art to this, and it's very important to think about the characteristics that are important to you as a person with lived experience with diabetes. Okay, so going back one more time to the clinical practice guidelines from Diabetes Canada, the national organization, there is a very smart algorithm that will kind of guide one through what might the right choices be at different points. So if we encounter someone who is living with type 2 diabetes and maybe newly recognized, or maybe have actually been living with diabetes at some point for some time, the algorithm starts up here at the beginning or at the top, that implores us not to forget the healthy behavioral interventions like healthy eating, being active on a regular basis physically, as well as thinking about approaches to maintain a healthy weight. And then depending on what our sugar levels might be, if they're a little bit above target or a lot above target, remember those numbers we looked at, 5%, 6%, 7% as ranges of average blood sugar over a period of time. So if it's markedly above target or a little bit above target, we'll think about certain medications. And if it's really, really high at the beginning, then we're going to jump in very urgently with some injections of insulin. But in these categories, so if you're a little bit above target, then the guideline will recommend that we'll start with this medication called Metformin, and we're going to talk a little bit more about that medication. If you're farther away from the target, then we'll likely start with Metformin, and also thinking about adding something else on top of that, because each medication might be quite good at lowering blood sugar, but there's a limit to how much it will lower. And on average, any one medicine at a full dose will lower A1C by about 1%. So you can see that if you're more than 1% above the target, then that's why you might need a couple of these different medicines. If we move further down the cascade, there's an important question that is asked, that if an individual is living with heart disease or diseases of the arteries affecting our brain or our belly or our legs, then there is an additional consideration that certain medications that are listed here might be nice choices, because they will have added benefit over and above lowering sugar, that they may also offer some benefit in helping with improving our risk of heart disease. And then beyond that, so we're going to talk about the different medicines that are listed in this graph in just a moment. And then beyond those considerations, we might also think about other choices of agents that can help address these clinical considerations, like we don't want sugar to go too low because that can be dangerous for some individuals, or we might be very concerned about weight gain, in which case these couple of medicines might be, or these medicines might be our optimal choices. And then other folks are living with other aspects of health that need to be taken into consideration, such as impairment of our kidney function, or issues with our heart, like heart failure, or might be planning to become pregnant. So all of these things will go into consideration when we think about certain medications. But most of the guidelines here in Canada, as well as in the United States and in Europe, will have a common first step in terms of medicines. And Metformin is the name of the medicine that is recommended first line in most guidelines. It's generally the first choice because it's safe. It is very inexpensive. It may offer some heart benefits. And we've been using it, gosh, for about 50 years now. So we've got lots of experience with it. The way that it works is by helping your body respond better to the insulin that your body also already produces. And it makes the body make use of that insulin more effectively. In addition, metformin may also lower the amount of sugar that's being produced from the liver. So the sugar that's floating inside of us, we think about the food that we eat, but there's also sugar coming out of stores from inside of us. And metformin is a nice first step to help balance some of those things. Every medicine has good parts. Every medicine also might have some bad parts or some side effects associated with it. And stomach upset is the thing that is often a feature with people starting off on metformin. So initiating with a smaller dose, building up gradually, letting your body get used to it is often the nice way of introducing metformin as a therapy. It is not very often associated with low blood sugar. It does not cause weight gain. So it makes it, all of these attributes make it a nice first choice for us. But often we need something more, because if we are living with an average blood sugar that's farther away from the target, or sometimes if we've been living with diabetes for a longer period of time, we may need some extra help from medication therapies. Previously, this family of medication that were called insulin secretagogues. What does this mean? It's not insulin per se, but it's a medicine that stimulates the pancreas to release more insulin, secretagogue. An example, the most common one that we used in Canada was a medicine called glyburide. It was often added on top of metformin, and the two together could work synergistically, because glyburide is like it's a medicine that kicks the pancreas a little bit and said, give me a little bit more insulin, that will help lower blood sugar. As a result of doing so, it is possible that people taking a medicine like glyburide might experience an overshoot of the sugar, and actually it might go too low. And because the more insulin that's kind of released into the system, it actually stimulates weight to be put on. So it was effective at lowering blood sugar, but people were concerned somewhat about using this medicine in all individuals because of these sorts of side effects. So there's been a tendency in recent years to move away from this category of medicines for people, especially when there was concerns about overly low blood sugars. Instead, we've been moving to newer categories of medications. And one family of these are called dipeptidyl peptidase 4 inhibitors, or DPP4 inhibitors. We recognize them because they will end in this suffix gliptin. Oh, there should be an L here. Allogliptin, linagliptin, sitagliptin, saxagliptin. We got this interesting cadence with many of our heart medications and diabetes medications, where families, you'll recognize families, it's kind of like they have all the same last name. These medications work by to lower blood sugar by increasing insulin levels after a meal to some degree, and also lowering another hormone called glucagon that tends to raise blood sugar. So it's sort of balancing out the hormonal balance that's often going in the wrong directions in persons living with diabetes. It has a somewhat moderate effect in lowering blood sugar. It does not cause weight gain. It does not cause excessive lowering of blood sugar. And on the heart, it was sort of neutral. So not better, not worse. So it's kind of middle of the road in many ways. Worked well in combination with the others to help lower blood sugar somewhat, but wasn't the real rock star of the diabetes medicine world. Newer medicines are kind of taking that mantle of, these are a little bit more exciting in terms of what they might offer us. And this family of drugs called SGLT2 inhibitors, sodium glucose loop transporter 2 inhibitor. These medicines work by eliminating glucose in the urine. I'll show you over the next couple of slides what that mechanism might look like. Examples of these include canagliflozin, dapagliflozin, empagliflozin. So the surname for this family of drugs are the gliflozins. The way that they work is that there's this interesting natural process in the body where sugar, whether we ingest sugar from food or it's produced internally because of hormonal stimulation from our liver or released from our muscles, the sugar circulates around. As many substances in our body do, they travel through to the kidneys. We've got 2 of them on either side of our belly, where filtering of all of the blood flow goes to. Sugar is usually filtered by the kidney and actually starts to enter the urinary system. But very smartly, the body, under usual circumstances, would say, you know what, I might need that sugar for calories and for energy later on. I'm going to hold on to that and reabsorb that. And that's where this sodium glucose loop transporter comes in to pull back the sugar under usual circumstances, so that if one was going to measure the amount of sugar in urine under normal circumstances, you won't find much at all. So urine is not very sweet. I don't encourage you to taste it, but that's the way that it goes when we test out chemistry. So interestingly, given that folks have discovered that sort of mechanism, some smart scientists figured out, well, if I'm living with diabetes and my sugar levels tend to be too high, if I understand that there is this transporter going there, well, maybe I can actually block it out. And if I do so, I will induce sugar to be dumped into the urine now. And on a net basis, I could actually lose about 200 calories per day of the glucose by using one of these gliflozin types of medicines in the body. So when I now taking the medicine, I'll lose sugar, my blood glucose will go down. And because I'm losing a little bit of calories, I'm actually going to lose a little bit of weight per se as well. And when sugar gets dumped into the urine, it drags along with it some salt and some water. So my overall fluid balance will also go down somewhat. And so if I'm prone to developing fluid retention, or if my blood pressure goes up because I've got fluid retention, then both of those things will be helped as well. So very interesting mechanism that, and you can tell from the story that I've just conveyed, that this class of diabetes medications might have some other positive effects on health beyond the sugar also. Lowering body sugar, lowering fluid, lowering blood pressure. And I will show you a couple of research slides in a few minutes that will address the question, if we do all of these things, will my heart be better off as well? I'll leave you to ponder that question. The way it's being set up is, that's an interesting sort of setup. Okay, another group of medicines that's gotten to be very exciting in recent years is another example of a second-line glucose lowering medication called a GLP-1 receptor agonist. So far, these have been injectable medicines that end in tides. So dulaglutide, exenatide, liraglutide, semaglutide. These are medicines that work with the body to increase insulin levels and lower glucagon levels. So we heard about that sort of mechanism before. These ones are more powerful and can have a bigger effect on lowering glucose, probably better than the oral medications that we've seen. The other interesting thing is that they probably have some effects on the gut in slowing digestion, reducing appetite, and their use has often been associated with some weight loss. For some people, it can be quite dramatic, of several kilograms over a few months. So this is very positive, given that many people with type 2 diabetes are carrying around extra weight, which may make the sugar control more difficult. We've heard of some medications that actually make that situation worse. This is one interesting medicine that or group of medicines that can make that situation much better. Lower sugar substantially, lower weight as well, which is very interesting. And while it's doing this, it has a very low risk of causing sugar to go too low. So quite safe in the way that it's kind of shaking out. These medicines are available as injectables. And then this latest edition is also coming to the market as an oral medicine as well, which for some people might be a nice innovation and another nice option. Okay, so we've got these different oral medicines, starting with metformin and different categories of medicines. Some people need to actually use insulin. I think we all recognize that the challenge for people living with diabetes is either a lack of insulin or the body's resistance to the insulin's effect. For younger people living with type 1 diabetes, their specific medical issues that their pancreas has stopped functioning and they're not making insulin. So they are dependent on insulin injections. For people with type 2 diabetes, some need insulin as an extra add-on to get the sugars down. For some people with type 2 diabetes, it may be the pancreas is getting tired over time, and that's where insulin therapy needs to be kicked in. And sometimes, if the sugar levels are very high when diabetes is first recognized, even in adulthood, then we might start with insulin, because that's the most effective and most rapid way of getting sugars under control. Gosh, there are many insulins that are available, and the Canadian Diabetes Guidelines highlights this as a table for reference. Broadly, what I wanted to kind of orient us on is that there are a group of insulins, and some of them are very old, dare I say, even going back to the times of Benting and Best 100 years ago. Well, we don't use those ones anymore, but there are versions of that have gotten better over time and have been manufactured genetically to be very pure, very effective, with lovely characteristics. And they're divided either into insulin types that work sort of a mealtime, or short acting, or bolus is its other kind of label. And there's several examples of that. Some of these names you may recognize. And then on the other side are insulins that work over a longer period of time, either a few hours or over the course of one day or even more days. So that's the insulin that works at the baseline or basal. And we might have other insulins that are injected throughout the day around meals as bolus kinds of insulin. So this next slide is going to show us an example of what that looks like. If this represents insulin levels over the course of a day, and you'll see that they go up and down through the course of the day in response to meals. Every time we eat something and it hits our gut, that's a stimulus to the pancreas to release insulin, so we can deal with the sugar load that's coming in from the meals. So we attempt to give insulins as medicines to try to kind of emulate what goes on with the body's natural insulin levels. This is what's represented from giving a long-acting insulin into the system. So here you're going to see that this really doesn't respond to any one particular meal, but rather it's giving some insulin that just gives us some coverage throughout the day and even a little bit through the night. And that might be okay as a baseline. This is what a human version of an insulin might look like. And this is what a kind of a manufactured analog version of an insulin might look like. And you'll see this one is even smoother and just kind of gives a slow, continuous amount of insulin throughout the day. But you'll recognize neither of these insulins gave coverage for the peaks that we really need to get to. So this is what's represented in a human formulation of an insulin that we might give like 15 or 30 minutes before a meal. It gets absorbed after some tens of minutes and goes up to a peak and comes back down. So this is pretty good, especially when it's combined with something in the baseline. And then the newer versions of insulin, why they're really interesting, is that they really mimic the physiologic kind of peaks and valleys of our normal or our usual insulin systems and pancreatic function. So many people who are on insulin will take a combination of one of these bolus insulins as well as one of these basal insulins together. So these will be multi-dose kind of intensive insulin therapies. Some people may also be using a mixture of insulins, and this is especially helpful if one needs assistance in giving these insulin doses, or if you're having challenges in taking multiple doses. The opportunity is to take a mix of a long and a short together in one single syringe. And in this case, this is an example of a human insulin that's injected in the morning before breakfast and again before the evening. You'll see it's not bad because it goes up and down, but really misses the peaks and the valleys to some extent and may carry over too much towards the bedtime. This is an example of what a newer version of an analog, the newer formulations might look like to get to more of that closer representation of insulin, but we might still be missing some coverage in the afternoon with the lunchtime meal. So these are different approaches from the injectable insulin therapies, and of all of these options, the goal is to find the one that works best with your physiology, addresses the sugar needs, and the combination of orals and injectables. Finding the right cocktail to meet your needs is your goal working with your healthcare provider. Okay, almost to the end of this, and I did want to end with addressing that intriguing question that if some of these medicines can lower blood sugar, but in addition, do some other interesting things like take fluid out of the body, lower blood pressure, lower weight over time, might they have some other important benefits on the cardiovascular system? So this has been looked at extensively over the last several years. And more recently, in the last 5 years, there have been a few medicines that have been looked at in detail for their benefits on the heart. So let me call out 3 studies that have a similar sort of story, a similar design, a similar kind of picture that we'll show with them. So let me start with this medicine called empagliflozin. So gliflozin, you'll remember that surname is attached to the family of medicines that belong to the SGLT2 inhibitors, the ones that help the sugar get pushed out into the urine. Empagliflozin was studied in several thousand people. 2/3 were given the active medication empagliflozin. 1/3 were given a matching tablet, a placebo tablet. These folks were followed over a period of 4 years. These individuals were living with diabetes and had other risk factors for heart disease, or actually had heart disease. And you can see that very early on, the red line is lower than the black line. And this carries out over these 4 years, and that on average, there was about a 14% lower risk of developing a heart problem, such as dying from cardiovascular disease, having a heart attack, or having a stroke, associated with use of this medication in particular. In a parallel kind of study done around the same time, another representation from that family called canagliflozin was also studied in thousands of people living with heart disease or with risk factors. And once again, 14% reduction in the chance for bad things to happen, like cardiovascular death, heart attack, or stroke. So interestingly, quite consistent. And then the third member of this family, dapagliflozin, also had a very similar outcome, and one more that I'll show you in a second. The other class of drugs, the GLP-1 receptor agonists, so the tides, liraglutide in this case, has been studied, and newer members of this class have also been studied in this way. Very familiar story once again. Thousands of people living with diabetes, half get the drug, half get placebo, over a period of 4 to 5 years, lower risk by 13 or 14% in bad things happening. So lowering sugar is a really good idea. Lowering sugar with drugs that offer up kind of these newer mechanisms and newer benefits might be a nice way of reducing cardiovascular events and protecting the heart. And even more specifically, for people who are living with heart failure, there might be some additional benefits. Heart failure is a condition, we talked about it before in sessions, that the heart's not beating as strongly as it might, that there's been some damage to the wall of the heart, so it's not moving so well. There's a tendency to hold on to extra salt and water, which gets us into trouble with fluid overload, shortness of breath, landing in hospital, needing for treatments to get rid of some fluid. So interestingly, folks started asking the question, if I use one of those special diabetes drugs that belongs to that SGLT2 family, remember the glyphosins that dump sugar, but also dump salt and water through the urine, then it might have an interesting benefit on heart failure. And indeed, that's what's been shown. Once again, interesting design. In this case, this was a big study that involved 17,000 people who were followed for about 4 years. And if we draw your attention to the red lines specifically, the dotted red line represents the episodes of cardiovascular death or hospitalization for heart failure that occurred in the people with diabetes who had reduced heart function and were receiving placebo. If instead you receive the active medication dapagliflozin in the solid red line, the risk of dying from heart disease or landing in hospital with heart failure was reduced by actually a large amount in this study, by as much as 38%, by choosing that right kind of medication. And you now would all say, well, that makes sense based upon the understanding of how these medicines work. So very interesting story and evolution of diabetes medicines over time. If you want to learn more, you can turn to the guidelines website itself at guidelines.diabetes.ca. There is great information for professionals as well as great information for patients. Here you'll see patient resources. And of course, we'd invite you to visit the Health University website. You're familiar with the Cardiac College website. Well, you can also come to this Diabetes College website. You can see the guide there. You'll see information that's familiar to you about getting active and eating well and feeling well and taking control, but there's also great information about treating diabetes as well. So I'm wondering if there are any questions that you might have online. I'll just pause for a few seconds there and see if anything pops up. If not, I'll once again consider that this was a comprehensive enough presentation to address any questions that you might have had. If you do have any questions that come up later on, please do connect with your rehab case manager, and she or he would undoubtedly be able to address that very well. But if they need to reach out to me or my colleagues, then we'd be pleased to do so and get back to you with specific responses. Recently, Healthy University and the colleges went on to social media. So Healthy University is now available on Twitter. And here's the handle @healtheu_TRI. So please do follow us and add us to your preferred list of information sources. The next session is actually tomorrow afternoon about exercise and living with diabetes. So we hope that you'll continue on with this theme of living well with diabetes, and we hope to see you again in the very near future for these educational sessions. All right, super. Thanks for joining us. Have a great evening, and continue to wish you great health. Thanks very much.